the remaining saline solution. With the patient's arm below the level of his heart, remove the syringe. Now connect the injection cap to the hub of the catheter. Remove excess blood using sterile alcohol swabs. Next, secure the catheter hub with sterile tape or steri-strips. Then apply a sterile 2-inch by 2-inch gauze pad over the site, followed by a transparent semi-permeable dressing. If your facility specifies it, flush the PICC with 3 milliliters of heparin. Make sure to attach a label to the dressing that includes the date and time, the length and gauge of the catheter, and your initials. After you've completed the insertion, obtain an X-ray to make sure the tip of the catheter is correctly located at the junction of the superior vena cava and the right atrium. After 24 hours, remove the transparent dressing and gauze dressing and apply a new transparent dressing without gauze underneath. Your patient may receive a non-tunneled catheter if his doctor expects therapy to last a few days, weeks, or months. These catheters are commonly used for rapid venous access in emergency situations, but they can also be used for many types of infusions. Non-tunneled catheters are available as single or multi-lumen devices of various gauges. Usually, a non-tunneled catheter is inserted in the patient's subclavian or internal jugular vein, with the tip of the catheter at the junction of the superior vena cava and right atrium. Sometimes a non-tunneled catheter is inserted into the femoral vein, with the tip in the inferior vena cava. This site should be avoided whenever possible, however, because it increases the risk of complications, such as thrombosis and infection. Advantages of non-tunneled catheters include easy insertion at the bedside, simple replacement over a guide wire, the ability to administer multiple infusions, and relatively simple removal. Disadvantages of non-tunneled catheters include easy dislodgement, a higher risk of infection compared to tunneled catheters, and the need for routine care. Although a doctor must insert a non-tunneled catheter, you may need to assist with the procedure. If so, gather the appropriate equipment and prepare the patient for insertion. One aspect of preparing the patient for the procedure is to teach her Valsalva's maneuver. By increasing intrathoracic pressure, it reduces the risk of an air embolus whenever the catheter lumen is open to the air. To teach Valsalva's maneuver, tell the patient to take a deep breath and hold it. Tell her to bear down as if straining to have a bowel movement for 10 to 12 seconds. Then have the patient exhale slowly and calmly.
Very good.
To prepare the site before insertion of a non-tunneled catheter, use scissors to clip excess hair from the site. Then clean the site using 3 alcohol swabs followed by 3 povidone iodine swabs as described earlier. After insertion, apply a gauze or transparent semi-permeable membrane dressing, according to your facility's policy. Then attach a label to the dressing that includes the date, the time, and your initials. As with all central venous access devices, you'll need an X-ray to confirm that the catheter tip is positioned properly. Tunneled catheters are more durable and biocompatible than non-tunneled catheters. In fact, they can remain in place for several years. One reason that tunneled catheters are so durable is that they have a Dacron cuff at the exit site. Tissue grows around the cuff, which anchors the catheter and keeps bacteria from migrating along the catheter tract and into the patient's venous system. There are 3 main types of tunneled catheters: the Broviac, the Hickman, and the Grochong. The Broviac catheter has a small lumen and is commonly used for children. It requires daily flushing with both saline and heparin. The Hickman catheter is similar to the Broviac, but it has a larger diameter and is usually used for adults. Hickman catheters can be single lumen or multi-lumen. The Grosjean catheter has a pressure-sensitive valve at the tip. It prevents the backflow of blood into the catheter lumen while allowing you to infuse solutions and remove blood samples. If your patient has a Grosjean catheter, you'll need to flush it with saline each week. A doctor will surgically insert a tunneled catheter into the subclavian vein and then thread it through the subcutaneous tissue so it exits through the chest wall, usually medial to the nipple. As with other central venous catheters, the tip of the catheter must be positioned at the junction of the superior vena cava and the right atrium. The main advantages of tunneled catheters are a lower risk of infection compared to non-tunneled catheters, and a minimal need for routine care after the site has healed. Disadvantages of tunneled catheters include the time and expense of surgical insertion, the need for a doctor to insert and remove the line, and alterations in the patient's body image. Because tunneled catheters usually are inserted in an operating room, your role typically will involve teaching the patient about the device, preparing the patient before the procedure, and monitoring the patient after surgery. A vascular access port, commonly called a VAP, is another reliable choice for patients who need long-term central IV therapy. A VAP can remain in place for several months to several years. A doctor must surgically implant a VAP, usually in the chest wall, but occasionally in another location, such as the arm. A catheter extends from the VAP to the same location as other central venous catheters, the junction of the superior vena cava and the right atrium. A VAP has a number of advantages, including the ability to withstand repeated access, little restriction on the patient's activities, few concerns about altered body image, and monthly routine care when the device isn't being used. The main disadvantage of a VAP is that it requires a needle stick to access the device. Children in particular may need a local anesthetic as a comfort measure. Another disadvantage is that the needle may become displaced and cause infiltration. Also, VAPs are the most expensive devices to place. Keep in mind that a VAP may be used for other purposes besides central IV therapy. It also may be used for arterial or peritoneal access. For that reason, make sure that all VAPs are labeled and documented clearly so they're used correctly. When choosing a VAP, a doctor considers the patient's age, vein size, and body size. If the patient needs multiple infusions or blood samples, the doctor may choose a dual lumen VAP. If the patient may require an MRI at some point in the future, the doctor may opt for a non-metallic VAP. A VAP may be considered high profile or low profile based on the height of its reservoir. The septum of a high-profile VAP is easily palpable under the patient's skin after insertion. That makes it ideal for obese patients. A low-profile VAP usually makes a better choice for a patient with a thin or normal-sized chest wall. A doctor must insert a VAP in an operating room. Consequently, your role typically will include teaching the patient, preparing the patient for surgery, and monitoring the patient after surgery. Before the doctor closes the incision, he'll use an X-ray or fluoroscopy to confirm the placement, stability, and patency of the device. If you're caring for a patient who has a VAP, you'll need to know how to access the device to check its patency, draw blood, and infuse medications. Your facility may require you to complete special training before you can carry out these procedures. To access nearly all VAPs, you'll need a non-coring needle. A non-coring needle has a deflected or angled tip that slices through the septum and, when removed, allows the septum to seal shut. Non-coring needles come in various lengths and gauges. However, you'll usually use a right-angle non-coring needle with an extension set. This needle has a special protective device to prevent needle stick injuries. Newer VAPs, such as this one, allow you to use an over-the-needle catheter. With these VAPs, only the catheter remains in place, creating a needle-free system. To access a VAP, Wash your hands and put on gloves. Palpate the port